Okay, for this lecture, we're going to be talking about cardiac output, basically just the amount of blood that is getting ejected from your ventricles. We're going to be looking at some factors that affect cardiac output. If you guys can kind of think again about all the stuff that we're learning, just layering onto itself. We started off just like with the basic anatomy, talking about ventilation and how there's forces that oppose lung inflation and how your lungs move open and shut. We went from that to then talking specifically about kind of like the smaller portion of gas exchange with the lungs, looking at Fick's law, surface area, difference in pressure gradient, and AC membrane thickness. And we really delved into looking at how there's a diffusion component of oxygenation where the oxygen has to diffuse from your lungs into your bloodstream. We looked in detail at hemoglobin as like the buses that are carrying that oxygen and how saturated they are or how full they are. And then the third thing that we looked at was circulation, which I always like to think of as kind of like the roads that the buses are on, right? Because you need something to carry the hemoglobin to all the areas of the body. So when we were talking about circulatory hypoxia, we looked specifically at cardiac output and how if you have a low cardiac output, that can very much affect how well you oxygenate. So here we're going to delve into specifically cardiac output and some of the factors that affect it. Okay, so again, cardiac output is the amount of blood ejected from the ventricles. So the formula here is cardiac output equals stroke volume, SV, times heart rate. Your normal or your average stroke volume is about 70 mils, and your normal heart rate is 60 to 100 beats per minute. The other thing that I kind of want to highlight here is because everything is a loop, your cardiac output of your left ventricle is essentially going to equal the cardiac output of your right ventricle. And if you think about why that is, if you kind of look over here at this heart, when you've got your superior and inferior vena cava draining the blood, the deoxygenated blood back from your body into your right atrium, it goes through your tricuspid valve into your right ventricle. That's then going to get ejected through that pulmonary artery into your lungs, and then coming back through your pulmonary veins into your left atrium, out through your mitral valve into your left ventricle, and then that one goes out through your aortic artery. Whatever comes through here is going to go to here. So this really is going to determine the cardiac output of your left ventricle because your right ventricle kind of leads into that. So that's all I mean by that. I don't know if I just made that more confusing with my explanation. I feel like I sometimes am guilty of that. Anyway, so normal cardiac output is 4 to 8 liters per minute, the average being about 5. So this is liters per minute. I do want to just really quickly here point out that there is something called a cardiac index. I feel like this is something that we use more in clinical applications. RT doesn't have a lot of usage for the cardiac index other than to realize when cardiac output is low, that's going to really affect our oxygenation. But cardiac index is taking the cardiac output and dividing it by your body surface area. If you guys click on this link, it kind of explains body surface area. But the reason that it gets taken into account in clinical situations is that this gives you a more accurate number because size really does matter for what your normal cardiac kind of blood flow should be. So the cardiac index is just a more specific version of cardiac output because it takes into account size. I am not going to do anything on the exam with cardiac index. I just thought it was worth mentioning because I feel like this is how it comes up more in a real world kind of application. So again, for cardiac output, the average is 4 to 8 liters per minute. Around 5 is kind of the middle number there. Just a reminder of this equation I try to put on each slide. So cardiac output, the total amount of blood pumped by the heart per minute. We're going to start talking about what affects cardiac output. So it's affected indirectly by preload, contractility, and afterload. And we're really going to dig into what those 3 things mean in the next couple slides. But just looking at the math, I have a couple practice math questions here. So during exercise, your stroke volume is 80 mils and your heart rate increases to 130 beats per minute. What is your cardiac output? So that's how this would be phrased on an exam. This is how you do the math. And then the next thing that I have is a bradycardic patient, so with a low heart rate, has a stroke volume that's also 80 mils. So I gave them the same stroke volume, but your second patient only has a heart rate of 40 beats per minute. So what is the cardiac output? So you can pause it if you want and do the math and see what you get for the numbers. So for the first one, you should end up with 10.4 liters per minute. Make sure that you include the liters per minute. And then for the second one, you should end up with 3.2 liters per minute. So you can see how, with the very same stroke volume, your heart rate really does determine how much your cardiac output varies. So this is an example of just the variety that you can see. So this drops all the way down to 3.2 with that 40 for the beats per minute. The reason that I wanted to point this out is when you are in a hospital setting and you have patients with different cardiac arrhythmias, we really like to pay attention to this because you do get patients whose heart rate drops down, especially in like the NICU and pediatric world. When we have small babies whose heart rates are low, we get very concerned pretty quickly because this is very impactful for their oxygenation. So I kind of wanted to show you an example where the stroke volume stayed the same, but the heart rate was the difference. So you could really see how that would be very impactful of your cardiac output. Stroke volume is the second component. So we talked about the heart rate. The other component is stroke volume. So this is the amount of blood that's pumped with each ventricular contraction. Again, the normal is about 70. So stroke volume is going to vary according to preload, afterload, and contractility. And we're going to define these here coming up. So preload, if you want to think about the heart in diastole in its relaxed state with the blood coming back from the body through the superior and inferior vena cava, draining into the right atrium and into the right ventricle, and then the blood coming back from the lungs simultaneously, because we know that the right and the left side of the heart are going to fill simultaneously, right, during diastole. And that can be hard to picture sometimes because we get so kind of bogged down by the order of blood flow. And it's not that that is not the order of blood flow, but a lot of this stuff happens concurrently or at the same time. So your heart is relaxed and you can imagine it filling on both the right and the left simultaneously. On the right side, you have deoxygenated blood coming from the body through the superior and inferior vena cava. On the left side, you have oxygenated blood coming back from the lungs through the pulmonary veins. So your heart is filling. This is kind of considered your preload. As it's filling, that volume is creating a certain level of stretch to your heart, right? Because as something fills, if you can imagine, as it fills, it's going to stretch those fibers. And we talked a little bit about the Frank-Starling law. The more something stretches, the more the heart stretches, because that myosin and actin filaments, which we didn't really get into, but the more the heart stretches up into a point, the more contractility it's going to have. So the more preload, the more stretching you have, which should mean the more contractility you have. So preload is a good thing. Preload is a filling. It means that your heart filled well, essentially, that you got a good volume in there. And I feel bad because I'm realizing now that I didn't define EDV, but preload essentially equals end diastolic volume. And I will make sure to kind of circle back and write that out there because I know when you're learning a lot of acronyms that can be tricky. But end diastolic volume. So what that means is, again, the heart fills during diastole. So at the very end of diastole, at the end of the relaxation phase, right before you go into systole or the contraction phase, end diastolic volume. This is how much volume you have in your heart before it contracts and ejects that blood out into your body and into your lungs. So end diastolic volume is what EDV is. I will circle back and make sure I put that on a slide. Sorry about that. So again, preload is that stretch. It's that filling of the heart. You want a lot of volume to fill into the heart before it beats. Contractility is the second component we're going to talk about. And this is, again, that Frank-Starling law. If you have this increased stretch, you should have an increased force of contraction. If you have more contraction, you're going to have an increased stroke volume. And just to kind of circle back and remind you, the stroke volume is the amount of blood that is ejected from your ventricles, okay? So if you have a high preload, that's good. It means you had a good volume of blood to eject out of your ventricles. If you have high contractility, that's good. It means that you have a strong force pushing that blood out of your ventricles. So preload is good, good volume. Contractility is good, good strength ejecting that blood out. The last thing, afterload, is the force or the load against which the heart has to work to eject the blood. So if you think about the fact that the ventricles, and I wish I had a diagram to pull up here, so I will definitely do that. We're going to talk through a diagram here in a minute. But if you can imagine, the ventricles have to eject their blood through the pulmonary artery on the right ventricle and then through the aortic artery from the left ventricle. So this is why it's really important that you guys know your circulation and the order that blood flows. So your right ventricle is going to eject blood into your pulmonary artery. That blood is going towards your lungs. Your left ventricle is going to eject blood into your aortic artery, and that blood is going to your body. Afterload is the resistance that ejection is going to meet. So as it's trying to push that blood into the pulmonary artery, there's a certain amount of resistance that it's going to face. That is called afterload. As your left ventricle is trying to push the blood volume into your aortic artery out to your body, it's going to meet a certain amount of resistance. That is considered afterload. So you don't want a high level of afterload. You don't want a high level of resistance because you don't want your ventricles to have to work harder than they need to get the blood into your lungs and into your body. Okay, you want this to be a low resistance system. And you can honestly almost think about afterload similar to how you think about airway resistance, because it's a very same principle in the sense that, as air passes through all of your airways, similar to how blood passes through your blood vessels, you don't want there to be a lot of resistance to that flow. You want air to be able to get where it's going freely and without much resistance so it can participate in gas exchange. Same thing with your circulatory system. You want that blood to be able to move through your vessels, move through your vasculature without meeting unnecessary resistance. You don't want it to have to work harder to perfuse through your tissues and participate in gas exchange. So you want a low amount of afterload. You don't want a lot of vascular resistance. You don't want your heart to have to work harder than it needs to. So one of the ways that I've seen this described, and Egan I think does a good job on this, and Egan doesn't always do a good job making things simplified, but I personally like this diagram. So if you think about preload as the tank of the fluid feeding the heart. So again, this is like during diastole when that heart is filling with that blood volume. It's undergoing a stretch, getting ready for contraction and systole. So it's filling. Then you come to the beginning of systole and you have that contraction. And that force of contraction is going to be what ejects that blood, right? And you want a good, nice force of contraction because you want to be able to get as much of that blood volume into your lungs and into your body. Afterload is the resistance of the vessel to the flow of the heart. So here you have a nice volume, it's contracting well and it's ejecting out, and it's going to meet a certain level of resistance, and that's the afterload. Your ventricles have to work against this resistance to get the blood where it's going. So I just have a couple of different examples. You guys can click on the links if you want, but for preload, you have this ventricular filling. The volume that you have at the end of diastole, the end diastolic volume, and this is what the ventricles have to work with. So whatever they fill with, that's the blood volume they have to work with. Your afterload is your vascular resistance. This can be an issue if you have semilunar valve issues, because if you think about the fact that your right ventricle and your left ventricle are ejecting through these arteries, if you have like a narrowing of these valves, or if these valves aren't properly opening, that can increase your afterload. It can make it hard for that ventricle to get the blood through there. So your afterload is what the ventricle is working against. Okay, so it's just another way to phrase those definitions to really help you to understand them. So when you're talking about all of these different things, it brings you to the second kind of math component of this lecture. We talked about cardiac output being stroke volume times heart rate. The second thing we're going to look at is something called ejection fraction. Your ejection fraction is the percent of your end diastolic volume that's ejected with each contraction. So your ejection fraction from a math standpoint is going to be your stroke volume divided by your end diastolic volume. So when we get into class, and I'll put these on some worksheets, we'll definitely practice this math. I always like diagrams. I think if you have a visual of what this is kind of talking about, it's easier than listening. But I'm just going to talk it through here. So your stroke volume is the amount of blood that is ejected by your ventricles, right? That's the blood that actually gets out of your ventricles into your lungs or into your body, right? So that's what's actually getting out. Your end diastolic volume is what could have gotten out. So if you think about your heart filling during diastole, it's relaxed, it's filling with blood, it's going to have a certain volume at the end of diastole. It's going to have this end diastolic volume. And right in before systole, right before the contraction starts, you have a certain amount of blood. Then your heart contracts and it ejects that blood into your pulmonary artery, it ejects that blood into your aortic artery, and only some of that blood is going to make it out, not all of it. And so the percentage of blood that makes it out is your ejection fraction. So I hope that that made sense. It's always hard to talk that through without like an example there, but that is your ejection fraction. So your ejection fraction is kind of used to figure out how efficient your heart is. A healthy heart should be able to get out 2/3 of your end diastolic volume. So if it fills up with blood during diastole, during systole, it should be able to get out 2/3 of the blood that it filled with, essentially. So if you look here, a normal ejection fraction is 50 to 75%. If it's 36 to 49, which is such a random pairing there, but 36 to 49, that's below normal. Basically, like the benchmark here is 50 and above, normal. 35 and below, super low. We would be very concerned about that. So I feel like that's kind of a good way to think about it. If it's 50 or above, you're in the normal range. If it's 35 or below, we're very, very worried. This would be a sign of a moderately sucky heart, basically. The reason that we care about the ejection fraction is if you're not getting out a high percentage of the blood that you could be getting out, that's going to affect your cardiac output, because we know that stroke volume times heart rate is our cardiac output. So if your stroke volume is getting smaller and smaller and smaller because you're having an issue with either preload, contractility, or afterload, because those are the three components that we're talking about when we're talking about stroke volume, you're going to see an issue with your cardiac output. So here are some of your lecture questions. We did some math ones that you guys can kind of have a chance to practice those. And then these are more conceptual questions. We'll go through this again in lecture. I have a little YouTube link here where it shows kind of a diagram explaining preload, contractility, and afterload. Just really understand those definitions, because I feel like on the exam conceptually, I ask a lot of things associated with, if you increased your preload, how would that affect your stroke volume? So just really be able to understand those components and how they relate to cardiac output.